My name is Emma Kate Burden, and I am going to answer Unit 4 Case Connections. I've decided to choose Case 1 and Case 2 to research and answer. So I'm going to start with Case 1. What we know from the question is that we have a newborn girl who's appeared normal at birth. Within 24 hours of her birth, she has become lethargic, hypothermic, and apnea. Her blood ammonia level is elevated, and her urine orotic acid level is elevated, but her plasma citrulline levels are normal. So the first question is asking what diagnostic would best distinguish between the urea cycle disorder and a disorder in beta oxidation. So first we need to know a little bit about each disorder. So the urea cycle disorder is a genetic disorder caused by a mutation that results in the deficiency of one of the 6 enzymes in the urea cycle. These enzymes are responsible for removing ammonia from the bloodstream. The urea cycle involves a series of biochemical steps in which nitrogen, a waste product of protein metabolism, is removed from the blood and is converted to a compound called urea in the blood. In the urea cycle, in some of these disorders, the nitrogen accumulates in the form of ammonia, a highly toxic substance resulting in hyperammonemia, which is just elevated blood ammonia. Ammonia then reaches the brain through the blood, where it can cause irreversible brain damage, a coma, or even death. So now I'm going to talk about beta oxidation disorder, where this is heterogeneous group of defects in fatty acid transport and mitochondrial beta oxidation. This is inherited as an autosomal recessive disorder. Beta oxidation disorders have a varied presentation with either neonatal onset, with hyperammonemia, transient hypoglycemia, metabolic acidosis, cardiomyopathy, and sudden death or even later onset of neuropathy, myopathy, and retinopathy. So now that we know a little bit about these disorders, we can see what test is best to distinguish between these diseases. So blood glucose test is the most appropriate way to diagnose beta oxidation and urea cycle disorders. Urinary acid and plasma glutamine tests are both used to diagnose urea cycle disorders and beta oxidation disorders, but these tests are really only used to detect specific areas of enzyme deficiency. So, and also serum fatty acid tests are very rare to test for beta oxidation disorders, so that wouldn't be the most effective diagnostic test. The second question is asking us what enzymes are most likely deficient and likely to be impaired in the urea cycle when orotic acid levels are elevated. So the buildup of ammonia leads to an increase in certain amino acids in the blood. The amino acid depends on the type of enzyme that is deficient, and orotic acid is the primary urinary acid that is observed to increase in the blood. And when orotic acid levels in the blood are increased, the enzyme ornithine transcarbamylase is deficient. Since there is an OTC deficiency, carbonyl phosphate builds up in the mitochondria and then leaks to the cytoplasm, where it is reduced into pyrimidine synthesis, and this makes orotic acid levels increase. So that's going to finish up the answer for Case 1, and now I'm going to move on to Case 2. So what we know about the question is we have a 4-day-old infant who's been diagnosed with phenylketonuria. And the first question is asking us which amino acid may become essential as a consequence of phenylketonuria. So phenylketonuria is one of the most common defects in amino acid catabolism where the body cannot properly catabolize phenylalanine. Phenylketonuria is passed down in a recessive pattern where both parents either have PKU or have a mutated version of the PAH gene that is passed down to the progeny. So the first step in metabolism is converting phenylalanine to tyrosine, and this cannot be done in patients that have phenylketonuria. The amino acid that becomes essential in this disorder is tyrosine. So when phenylalanine cannot convert tyrosine, this leads to a tyrosine deficiency. And if a patient cannot convert phenylalanine to tyrosine, this causes a buildup in phenylalanine, leading to seizures and neuronal development defects. And so the second question is asking us about potential causes of phenylketonuria. So plasma phenylalanine levels were too high, so a dietary restriction therapy was monitored for 14 days, and then the levels returned back to normal. And potential causes of high levels of plasma phenylalanine could result from phenylalanine intake from food being too high, which causes the release of excess phenylalanine into the bloodstream. Intake of food or medical formula is too low, which causes the body to break down its own muscle tissue for nutrients, releasing phenylalanine into the bloodstream. A child's rate of growth has slowed, meaning less phenylalanine is being used to build new proteins, or it could be illness, which makes it difficult to eat or drink medical formula that can cause higher phenylalanine levels from the breakdown in the body's own muscle tissue. So another patient is also being evaluated with suspected PKU. BH4 loading tests are performed on both patients, and the results are shown in the graph given to us. The last question is asking us to summarize the test results from patient A and patient B. So the information given lets us know a little about BH4 loading test, and the graph is measuring the amount of phenylalanine in the blood after the patient is given tablets of synthetic cofactor. And we see that patient A, the levels after it's given the tablet is slightly increased over time, while patient B decreases quite a lot. So when the patient is given BH4 loading test, phenylalanine concentrations in the blood are supposed to decrease due to tetrahydrobiopterin, which is another name for BH4, being consumed by the patient. And BH4 is used because it helps stimulate enzyme activity and lower serum phenylalanine. So for patient A, as I've mentioned before, phenylalanine levels are slightly increased. Therefore, the BH4 did not stimulate enzyme activity in order for the patient to lower these levels. In order for this patient to lower these levels, dietary intake should be monitored. And moving on to patient B, we see a decrease in phenylalanine concentration. Therefore, BH4 loading tests worked, meaning the enzymes were stimulated and it was able to convert phenylalanine to tyrosine. So that is going to wrap up the case connections for Unit 4. And again, my name is Emma Kate Burden.